Oh, shoot. Okay.
All right,
Well,
Kevin, we're good to go.
I lost my agenda here. It went away. All right. Well, I'll go ahead and call this meet. You said we're good, Paul? We're ready to go?
Yes.
All right. I'll go ahead and call this August 4th Health and Wellness Advisory Committee together. I want to thank each of you for taking your time, for being leaders in our community, and helping the city of Charleston with our decisions on health and wellness. Just let you know, the city of Charleston knows how fortunate we are to have the expertise and the leadership that we have from each of you. So just want to say thank you. I think Paul sent out a lot of things on Monday, but I think part of that was our minutes, and I think we need to approve those. Can I get a motion to approve the minutes from our last meeting?
Motion.
Can I get a second?
Second.
All in favor?
Aye.
Any opposed? Okay, so we have approved the minutes, and I don't know what happened, but my agenda just went away.
Do I have an agenda on the screen for you?
Oh, you do? Okay, great. Okay, very good. All right, so if Ashley Hink would please give us her update, and we'll move on to item number 3 on the agenda.
Hi, good morning, everyone. I'm Dr. Hink, one of the trauma surgeons and public health researchers here at MUSC. And I know I've met some of you previously on these calls and meetings. So thank you for having me back. And I have some slides and presentation information, but I think we might just want to talk today because I think I've come and done a lot of presentations to the mayor's office, but I think that it's better to just convey what is happening in our city and the need for investment and support from the city. So we started our hospital-based violence intervention program. It went essentially live this last month. And for those of you who might need an update on what this looks like, it's a comprehensive program that provides wraparound services to victims of violence. Our focus is on youth and young adults between the ages of 12 and 30 that experience mostly gunshot wounds, that are victims of community violence. That includes drive-by shootings, retaliation, conflict-related, and we are serving additional victims of violence as well that might fall outside of that criteria. We focus on these individuals because they're the most high risk of having repeat violent injury, of having poor outcomes, social, economic, education. They're at risk of dying from homicide when they survive an injury, and they're at risk of retaliating and actually participating in violence and entering the criminal justice system. We have the 5th highest homicide rate in the country. We know that violence has been going up across the country this last year. However, in the state of South Carolina, our homicide rate has increased 40% in the last decade. Our state has been on a very, very poor trajectory for a long time. Charleston saw a doubling of its homicides last year alone. That's much higher than a lot of the cities saw across our country. And right now, those numbers are not going down compared to last year. Our program employs individuals from our community, and I'm actually going to pull them up because they are the meat of this, and I think it's really important to look at who they are. So I'm going to share really quickly. These individuals show up in our trauma bay when we have victims that come in after they've been victimized by a violent injury. And so we have Dr. Ronald Dickerson, who is born and raised in the East Side. He has a PhD and a master's in social work. He's been involved in education, starting high-risk community organizations that support high-risk individuals, and has just been a really fantastic member of our community, serving in this realm for a long time. We have Mr. Donamichi Singleton, who has been involved in grassroots organizations with anti-violence messaging, supporting at-risk youth, and being heavily involved in our community before stepping in our doors. And we're so incredibly grateful to him. And then we have Mr. Keith Smalls, who is a survivor. He lost his son from gun violence, and has been involved heavily in creating a nonprofit mentoring group to support high-risk youth in our community. We have an incredible group of stakeholders, both at the institution and in the community. We have the support from many nonprofits, the school system, both North Charleston and Charleston Police Department, and they've been our partners for a long time. So these gentlemen show up in our trauma bay when we have victims of violence to form relationships with our patients early on. They identify what their risks are, how they can help them, how they can help support their families, and they provide immediate mentorship, immediate support, and ask the question, what is it that we can do to make sure you don't have this happen again, and to try to stop retaliation. We had a shooting in our city last week where we had 5 victims show up at the same time. 1 died. They were all young people in their teens and in their 20s. This was a retaliation shooting from something that happened a couple of months ago where another individual that I cared for showed up dead on the scene from the same neighborhood. These are opportunities for intervention. These are evidence-based programs that have been supported and implemented across the country. They're gaining more popularity because they have evidence behind them, because right now the federal government is telling communities, telling cities, telling states, look, you need to do something because these are evidence-based programs and are actually providing support. American Rescue Plan money can be used to do this and is being encouraged for cities and counties to use this money in this way. Some of these programs are in the budgets every single year because they're demonstrated to reduce repeat injury, reduce recidivism, and improve social and economic outcomes for individuals. Because these gentlemen, when they show up, they put together an action plan for the patients and their families. Employment, housing, mentorship, whatever it is that they need, helping get an ID, helping leave a gang, whatever it is that they need, they put together these action plans for them to help address the underlying risks and roots of violence, in addition to sending anti-retaliation messaging about firearm carrying. They work alongside of other community groups. They were alongside of our police right in the trauma bay when they showed up the other day. They follow and work with individuals for months after injury, sometimes upwards of a year. This is a service that is not expensive and has the opportunity to save lives and actually demonstrate to the community that Charleston and its surrounding neighborhoods are actually doing something. But police cannot do this alone, and they say that publicly. Violence is complex, and we have to address it as a complex public health issue. And this is how it's done. Since these gentlemen have showed up and started working with our patients and families and alongside of our staff members, there's an overwhelming sense of relief because all of our nurses, doctors, everyone says, oh my gosh, we've needed you for so long because we keep taking care of victims of violence and sending them out without resources and without support. We don't have social workers and DSS to help 18-year-olds who get shot. We do not have coordinated services that are evidence-based that wraps around these individuals and these young people and their families to actually address the underlying risk and roots of violence. Studies show that the cost of homicide to society is anywhere from $13 to $17 million. Okay. Putting money into prevention, even if you prevent 1 or 2 homicides, and our goal is to prevent a lot more and certainly a lot more non-fatal firearm injuries and other forms of violence, that's a profound return on investment. And these programs have shown that for every dollar invested, you save $4 alone in healthcare. Most of these patients that we care for do not have health insurance, so it's a significant burden on the healthcare system as well. Not to mention, they're less likely to re-enter employment. There's profound effects on their family if they have disabilities, right? PTSD, the trauma of this, the trauma that children and people in the neighborhoods are seeing and experiencing, right? And so this program and this team, which we hope to grow with more support, has the ability to do so much incredible work in our community. It's being done elsewhere. We have to have support. We have startup funding that was graciously given by MUSC, right? And this is not a money-making program for the hospital. There are other states that are getting Medicaid and other institutions to help pay for this because they're recognizing the value of this work and the return on investment. But South Carolina currently does not have a real investment or concentrated effort to really do something about gun violence and about youth violence, even though we're leading the country right now in homicide, and it's now the leading cause of death for children. Cities are taking this on. Charlotte, they are funding a program. Atlanta, they're funding a program. This has all been happening over the last few months, some of which is using their budget money, some of which is using ARP money. This is happening all over the country. UAB in Alabama, they're using public health money to start one as well. This is not something that's just happening in the Northeast, but the Southeast, including South Carolina, has the highest burden of violent injury. This is an opportunity to do something in addition to funding community violence interruption work, which is also gaining a lot of attention and popularity to help prevent retaliation. And so I'll say this, we're so excited to have this program. We've already started helping and serving a number of patients and their families and have enrolled approximately 6 people for long-term follow-up, in addition to providing homicide support, counseling to other individuals that we've been encountering and helping. And so over the next year, we anticipate serving 80 to 100 people directly with those long-term services. And that's a huge trickle-down effect when you think about their families and their communities. We need long-term support and sustainability. This program will disappear if we don't have that. And so this is an opportunity for the city to step up. North Charleston is entertaining this. I've already presented to their city council a couple of weeks ago in a meeting with their mayor this week as they are entertaining, supporting a portion of this. Over 75% of the patients we serve are from Charleston and North Charleston. About 34% are from North Charleston, and more than that are from the Charleston area. This is an evidence-based investment that could actually demonstrate that the city is committed to doing something and supporting an effort like this. And so we're so happy to have this off the ground. It's already making a difference. We've had patients get jobs, get safe housing, leave bad environments, open up bank accounts. These are the real things that are tangible that can make a difference for our patients in our community, that help people escape paths of violence. And so thank you for letting me give you an update. I'd certainly love to come back once we're a few months in and could give you really, some of our evaluation data, because our job too is to be able to report what we're doing and some of its long-term evaluation. And we reevaluate our patients every 3, 6, and 12 months after enrollment to make sure they're getting services and staying free of violence and to assess some of their other outcomes. But again, this is modeled and supported after national organizations that have demonstrated efficacy in other places. And so I certainly welcome any questions and thank you for the update. But I think it's important to have a strong message of this is still happening in our community and we certainly need more support. And I think dedication from the city to say that we care that our youth are dying and that we need to do something to support these evidence-based efforts in the community. So thank you.
Thank you, Dr. Hank. Very good report. I appreciate that. And, I guess, we're very concerned, obviously, the increase in violence lately with the city of Charleston. I mean, it's one of our, one of our top priorities right now. And can you give me a little more information on exactly what the city of North Charleston's doing? You said you brought it to them.
Yeah, so they asked for a proposal to help potentially fund this effort. And so I have been in contact with youth advocate programs. They have programs all over the country to provide community-based violence intervention and interruption services. And so we have teamed up to propose a combined effort to provide hospital healthcare-based services to victims that we care for in our institution that are victims of violence. And youth advocate programs, YAP, has put forth a proposal to provide intervention services for individuals identified in the community before the experience of violent, potentially life-ending violent injury from the juvenile justice system, from the school system, from other nonprofits. And they would provide intervention services similar to the ones that we provide, but identifying, youth, teens in the community first, in addition to providing violence interruption in hotspots of violence. So they've identified 4 specific neighborhoods in North Charleston that are hotspots and would provide violence interruption there. And so we have proposed to them, to North Charleston, that they support a third of our budget, because I have very, very rigid data about the patients that we care for that demonstrates that a third of them come from North Charleston. And so I can report that to them and ask for them to help pay for a third of our budget. Our budget runs about $325,000 to $350,000 a year. And so really it's a small sum of money for a potentially very large impact. And they're entertaining having youth advocate programs have a more substantial, it's more costly because they're providing direct services within the neighborhoods and schools to more people, and they have to employ more people. And so they're entertaining supporting them as well. And I would say too that we have put in a federal grant to the Department of Justice to provide that similar model to serve both the east side and the west side of Charleston. However, it's an incredibly competitive grant. And of course, it would be only short term. And we won't know if we get that until October, November. But that kind of model could be very meaningful on the peninsula where we have hotspots of neighborhood violence, where we can provide services to victims that come from Charleston, but then have an evidence-based program in the community in these neighborhoods where most of our violence is coming from. And we know exactly where it's coming from.
Okay, well, thank you. Yeah, I mean, I definitely think that this is something that we should probably bring before city council, you know, and discuss, and maybe have you even give a little bit of a report if you'd be willing to, Dr. Hank, you know, to our city council.
I would love to. And I would be happy to inform them and can certainly show them, you know, the details of these programs and what we're doing so they understand.
All right, thank you. Mayor Techler.
Mr. Chairman, if I may interject, first of all, thank you and Dr. Andrews for your continuing efforts along these lines. And we got out of the community assistance business in 2021 based upon our budget shortfalls from COVID, but I'm going to recommend to council that we reinstitute that using some of our ARP money. So I hope in the next 30 days or so, we'll have a little RFP for community assistance requests, for grant requests, if you will, for things that are relative to COVID. And and it's pretty broad, so this would qualify. But I will share with you, and you probably know this, but Charleston County got a heck of a lot more money than the city did, and even North Charleston got more than the city did. It's something to do with their formulas. But Kendra Stewart with you might have seen with the Riley Institute is making recommendations to Charleston County. They have $80 million. We got 10. That's a good bit of money, but we had a $40 million shortfall. So that might be a good opportunity. And then I just wanted to share with you and the folks here on the committee that the city has been addressing this through other venues. Our office of the Mayor's Office of Children and Families has built a coalition of mentoring groups this year, and we're supporting them and building mentorship in our community and through our police department. So we do have other activities that we are trying to influence and mentor youth. I got to be honest with you, 16, 18-year-old kids, if you will, unfortunately are at the point where they are as hardened as you can imagine. And, you know, we got a real kind of crisis situation with those individuals. I understand from the shooting last week, and maybe there was a bit of retribution involved, but, you know, they were playing a game of dice. And I don't know if the roll went wrong or, you know, but just resolving simple disputes with pulling out the guns, and it was like a shootout at the OK Corral. A few weeks ago, a gentleman from out of town had an incident. He was murdered when he asked some young adults, you know, to be quiet, and they didn't like being told to be quiet. They followed him up to the apartment and killed him. I mean, it's really sad and scary, y'all. And we got to catch kids earlier than what we've been catching them, and we've been dropping them, you know, to start with. So anyway, thank you for the work you do, and please send us a proposal when we open that back up.
And Mr. Mayor, is this something we would also want to bring over to the Public Safety Committee? or just come right out of here to city council with it?
I'm going to be bringing it to the budget ad hoc committee actually in the next few weeks, and then we'll be able to open up for applications, I think.
Okay.
Yep.
And Dr. Hink, our next council meeting is August 17th. If you want to just kind of put that on your calendar, and we'll see if it gets on the agenda, and maybe have you make a little presentation if that's acceptable to you, Mr. Mayor.
Thank you.
Okay.
Can you, excuse me, Mr. Mayor, can you share who leads that coalition of mentors so that we can connect with that person?
Mindy Sturm.
Thank you.
She's head of our Office of Families, Youth, and Children. Mindy Sturm. Paul can connect y'all maybe.
Great, thank you.
Thank you.
Any questions for Dr. Hink? Or any other questions at all on this agenda item? Okay, well, thank you again, Dr. Hink. Very good report, and obviously of utmost importance. We appreciate all your work on that. Thank you so much.
Thank you for having me and letting me update y'all, and thank you for your support.
All right. So we will move on to number 4 on our agenda, the South Carolina DHEC homicide and suicide death presentation that Susan Jackson's going to give us, I believe.
May I introduce her? Would that be okay?
Oh, sure, Dr. Richardson, please. Yes, thank you.
Okay, so Susan Jackson comes to us today as the program manager for the South Carolina Violent Death Reporting System and State Unintentional Drug Overdose Reporting System. And I connected with Susan around the time that this committee was working on the grant to address social determinants of health in several zip codes, primarily 29403, 29405 here in Charleston, as a way to address the disparities in life expectancy that we have talked about frequently in this meeting. And as part of that, Susan and her group, led by Emma Kennedy, who's also on the call today, graciously agreed to drill down to look at the data for these zip codes. And when she sent it to me last week, and I then sent it to Paul, we thought this would be important time to bring this important data to our group. So thank you for giving time for this presentation. And Susan, the floor is yours.
Thank you so much, Dr. Richardson. We appreciate this opportunity. And we've added just a few slides to this presentation, I think, from the ones that were sent out. But we are grateful for getting this data out to you all. Just a quick acknowledgement, we are funded through CDC, and then this program it's absolutely made possible by the terrific support from our county coroners, and then the county and municipal law enforcement, the sheriffs and the police departments, and then those that contribute to the death certificates, and our work internally with getting that information from vital statistics here at DHEC. So a little just background about the program. South Carolina was one of the first states funded back in 2002, and we began collecting data in 2003. And we collect data on homicide, suicides, undetermined intent deaths, unintentional firearm deaths, and legal intervention deaths as well. And one thing unique about this system is that we do collect information from that death certificate and combine that with information from the coroner report and then the law enforcement reports. And we also combine incidences. So when you have a multiple victim homicide, it's not, we won't just look at an individual decedent. We'll combine those victims into one incident. And specifically, we're looking for circumstances. What happened prior to that homicide? That data that we can get out to our prevention partners, and what can we do to prevent homicides and suicides as well? And we information there about the manner of death, and we rely on those ICD-10 codes. And then throughout the presentation, the injury zip refers to where that homicide or that suicide occurred, and then the resident zip, of course, is where that decedent lived. And my colleague within our Bureau of Population Health Data Analytics and Informatics, Ms. Katie Shields, is going to take it from here.
Thank you, Susan. As you see on the screen, this is just by the numbers, some homicide and suicide deaths in Charleston zips, the total Charleston zips, 29403 and 29405 specifically. The top row shows the injury location deaths. So in all of Charleston County zip, in all of Charleston City zips, there's 977 homicide and suicides from 2003 to 2018. And then there was 1,060 residents who died, but some of these residents could have died outside of those Charleston zip codes. Then among zip code 29403, there was 126 homicides and suicides and 101 residents. And then 29405 saw 176 homicides and suicides occur in that zip code, and then 186 residents passed away. Next slide. Here you can see a breakdown of each of the zip codes with homicides and suicides. So you can see that zip code 29405 residents saw the largest number of homicides and suicides combined out of all the Charleston zip codes. And this is largely due to the number of homicides. You can see that in 29405, of the 186 homicides and suicides that occurred between 2003 to 2018, 147 of them were homicides, whereas 39 of them were suicides. This is different where you see in zip code 29412, they had 137 homicides and suicides, but this number was largely made up of suicides where you saw 112 suicides. Next slide. Here is some homicide and suicide combined demographics for age. And regardless of the zip code 29403 or 29405, the largest rates that we saw was among that 20 to 39 year age group. And they saw that highest rate, including zips 29403 and 29405, with 29405 having that by far the highest rate with 1,275.8. Now, when we look at it by sex, when you combine female or look at females and males with both homicides and suicides combined, you see that males have a 6.6 times average higher homicide and suicide death rate per 100,000 residents in the Charleston city zips when compared to females. And this is consistent with how we usually see males having that higher rate of homicide and suicide. Next, we're going to look at it just based on homicide deaths, so not combined with suicide, to see if there's any differences. So here we have by the numbers, so percent of homicides among residents in Charleston zips, both 29403 and 29405, 43.6% of homicides among residents were in 29403 and 29405. And you can see that 29405 made up 28.6% of all the homicides, and then 29403 made up 15%. And this just shows about residents and the location. So in that first tab or the first row, you see 29405, and there's 148 homicides, and 21 of those occurred outside of South Carolina. 7 of those occurred outside of the city. And then you can see the various locations. So 72 of those did occur in 29405, 19 occurred in 29403. And then the 2 other zip codes that popped in. And then with 29403, you can see that 16 occurred outside of South Carolina, 40 occurred in their zip code, and 11 occurred in that 29405. So as you can see, most of those are either occurring in 29403, 29405, and then we did have some outside of South Carolina. And this is a homicide trend, a 5-year rolling average for homicides in Charleston 29403 and 29405. So 29405 is that darker blue color, and they saw the higher homicide rates throughout 2003 and 2018 when compared to Charleston City Zips as a whole. And then you can see that 29403 for the most part also sees higher rates than Charleston City, except for that 2015 where they were slightly lower. But for the most part, 29403 and 29405 are consistently higher. This is a homicide death rate map using this 2003 to 2018. And you can see that 29405 saw the highest homicide death rate at 526.8. And that's that darkest shade of blue. And then the surrounding areas are lighter. And then 29403 is the second highest. So both of these zip codes are definitely areas of concern when looking at homicide deaths in the city. When you look at it by age, this is similar to when we looked at it with homicides and suicides combined. So that 20 to 39-year age group is seeing the highest homicide death rate in the city, followed by the less than 19 for 29405. 29403 saw 40 to 59 with a slightly higher death rate than the less than 19. Among sex, this is once again, you see males are having an average homicide rate 6.72 times higher than their female residents of that zip code. So you can see that among the residents of 29405, they have a homicide death rate of males have a homicide death rate of 876.5 per 100,000 residents, which is a lot higher than their female rate at 130 and the city zip, which was at 326.9. And then when we look at it by race, here you can see that Black or African American see the highest homicide death rate compared to their white, two or more races, and the total. So you see that Blacks on average have a higher homicide death rate that was 10.3 times higher than their white counterparts. And this is a similar trend for both 29403, 29405, and the city. And like Susan mentioned, NVDRS is able to capture some of those mechanisms. So how are these homicides, what mechanism is being used? And this one on the left shows Charleston City residents. So 75.1% of homicides were used with a firearm. And then in 29405, that percentage increases to 83.1% using a firearm. And then within 29403, it's roughly similar to this city at 76.6. But regardless, firearms are making up at least 3/4 of all of the homicides, followed by usually a sharp instrument as the second most common. Also, we have some circumstance data that we can share, and you can see that the largest homicide circumstance among Charleston residents is argument, with 111 of those Charleston SIPs showing argument, followed by precipitated by another crime, intimate partner violence, and a fight between two people. So a little summary, just looking at homicide, you can see that 44.1% of homicides among residents in Charleston ZIPs are in 29403 and 29405 zip codes. The 29405 zip code did see the highest homicide death rate at 526.8 per 100,000. The 20 to 39 year age group was consistently higher in the number of homicides regardless of zip code. The most common weapon that was used as a mechanism was firearm, regardless of the location of injury or the residency. Firearms is the leading one. And the circumstance was an argument that was preceding death. Next, we're going to go and do a little bit more in depth on the suicide deaths, similar to what we showed with homicide.
I just wanted to check in. I know we had a limited amount of time. Are we okay to go through these as well?
Sure, absolutely.
And once again, we show just this by the numbers piece, and we can see that this is a little bit lower than the homicides. We see 11.4% of suicides among residents were from those who were living in 29403 and 29405, with 29405 making up 7.1% of all suicides in the city and 29403 making up 4.3%. And this is once again that cross tab, so you can see if if the suicide's actually occurring in the zip code of residents. And so for the leading top five residents with the number of zip codes was 29412, 407, 406, and 414 and 418. So none of 29403 and 29405 weren't even in the top five leading zip codes for suicides. Here's a rolling average of the suicide rate per 100,000. And like it was implied in the last slide, both 29403 and 29405 have lower rates of suicide compared to Charleston City. And they have been, 29403 have been on a declining trend, but then more recently we have seen an uptick beginning in 2016 in suicides in both 29403 and 29405. Here is the suicide death rate map, and it looks very different than the homicide death rate map. So you can see that, 29405 isn't that darkest shade of green, and neither is 29403. We see the biggest shade of green in that 29412 zip code. So that is where the biggest burden of suicides would be occurring, is in 29412. When looking at suicide demographics by age, you see 29403 and 29405 saw a slightly lower suicide death rate. And then the 60+ year age group is where you see a higher number than that 20 to 39, especially in Charleston City. You see 40+ has a higher rate than those less than 40. And this is pretty consistent throughout as well. When looking at suicide by sex, it's similar to homicide, where you're seeing the males having a higher suicide rate than their female counterparts. So males on average had a 7.1 times higher rate of suicide per 100,000 residents than their females, with the higher rates being in the Charleston City compared to 29405 and 29403. When looking at it by race, you can see that white Charleston residents saw an average rate of 3.13 times higher than their Black counterparts. And this was very similar to both 29403 and 29405, where the whites have a higher rate. It was interesting to see that actually in 29403, there was a slightly higher rate of suicides among Black residents compared to white. Once again, we can look at mechanism of injury with suicide, and you can see that compared to around 3/4 of homicides that were using a firearm, suicides around roughly half of suicides were using a firearm. It was still the leading mechanism for suicides, but just a little less of a percentage. The next was suffocation or strangulation was the second leading mechanism for all zip codes. And once again, we can look at those circumstances so we can see what precipitated that suicide. And the leading circumstance was mental health problem, followed by a depressed mood, an intimate partner problem, and physical health problem. And these are the total number of suicides, and you can see that those are the leading 4 circumstances. Here are some suicide-related behaviors, and you can see the leading ones were disclosing a suicide intent, history of suicide attempts, left a suicide note, and history of a suicidal thought. So these are some behaviors that are preceding that suicide. And the summary for suicides, 29405 area saw the lowest suicide death rate in Charleston at 108.5 per 100,000 population. The 60 and older age group in 29405 had a rate 4.8 times higher than their counterparts in 29403. Men had an average rate of 7 times higher than their female counterparts. Over 50% of suicides were carried out with firearms, regardless of the zip code. And like we mentioned, that strangulation and suffocation was the second leading mechanism for suicide. Mental health problem was the most common circumstance for suicide in all Charleston zip codes. And then the most frequently cited behavior associated with suicide was disclosing suicide intent, followed by that previous history of suicide attempts. And then I'll pass it back to Susan so she can go over some of the data limitations.
Thank you, Katie. And just quickly, so we do follow data suppression rules, and you saw some of that more so in the suicide death information. And then we are, we are lagging. So this data reflected again years 2003 through 2018. We just finished data collection for 2019, and that's usually available sometime in the fall or winter. And then, we don't collect place of death zip code. And I know that's been a point of interest from some other data requests, but currently we don't collect that information. But again, thank you all so much for this opportunity to present.
Thank you, Susan and Katie. I appreciate that. Any questions for Susan or Katie on here? I didn't know if you could go back to, there was a slide on there that broke out by zip code inside city and outside city for the homicides when you first started. I just wanted to see if we could glance at that again, if we possibly can. It was way back toward the beginning of the presentation, so I apologize. Yeah, let's see. All right, so on there you have outside the city of Charleston was 7 on there, and I'm trying to figure out here 29405. Do we have a split between North Charleston and Charleston, because that zip code is split, or is that just when you say outside the city, is that outside of both cities? If that makes sense. That may be a confusing question.
Yeah, I think it was outside both cities, since we
Okay.
didn't do a proportion of the zip code that fell within Charleston city limits and North Charleston city limits.
Okay. So when we say those are the ones that are inside the city, could be in North Charleston, some could be in Charleston, some could be in North Charleston then. Okay.
Yes, that's correct.
All right. Thank you. Mayor Tecklenburg.
So a comment, if I will, Mr. Chairman, and thank you, Katie and Susan, for that report. Boy, that's something for us to chew on, and I'd love to get a copy of your information if you don't mind sharing it with us. But it certainly bears out what we've been tracking for some time, as Dr. Richardson mentioned. The life expectancy of our region is the lowest in 29403 and 29405, generally speaking. And it's clear an impact on that life expectancy is homicides. I do want to point out that 29405, and this is why I reached out to Mayor Summey, by the way, and to some council members up in North Charleston that I know and interact with, to be a part of this effort going forward, and they will be a part of it. Most of 29405 population is technically in the city of North Charleston, but this is a regional issue. It's a national issue for that matter. I've heard that suicide is now the second highest cause of death among young people up to age 40 or so in the country, not just in 29403 and 29405. This is everywhere. The homicides is the big number in those two zip codes. So anyway, I just wanted to share that we need to continue to draw in our partners, colleagues up in North Charleston to be a part of this effort, and they will be.
All right, thank you, Mr. Mayor. If there's no other question, Meredith?
Yeah, I got just a quick question. From some of the numbers when you indicate poisoning, has anything been or any data brought up that y'all have researched concerning the deaths of either warranted or accidental opioid overdose? Has that been thought of or brought into the equation?
We do currently collect some information on overdoses, but we just began, we were recently funded for, it's called Suitors, to begin collecting information on unintentional and undetermined overdose deaths. That data is actually due in August and throughout the fall. So we hope to have data on that sometime again in the winter that we could certainly bring back to you all. But South Carolina was just funded within the last 2 years to begin sort of expand. So it's what you see here, but then there's another module within that system that will help us look at the overdoses occurring here in South Carolina.
Great, thank you. I appreciate that.
Any other questions before we move on? Okay, I want to call on Dr. Katie Richardson to give us our community health update, if she would, please.
Thank you, Kevin. And I just want to thank Susan, Katie, and Emma. And my apologies for not introducing Katie. I work with her closely. She is a real data guru for COVID as well as injuries. And so thank you for joining us as well today, Katie. And Mayor Tecklenburg, I can certainly get you any of their contact information if you would like to contact them directly. So thanks for having them. I just wanted to spend a few minutes talking about COVID. I know everyone's tired of COVID, but as many people have said now, we're done with the pandemic, but the pandemic is not done with us. So Paul, do you want to bring up the slides that you shared with me? So Tracy McKee unfortunately could not join us this morning, but she and Paul pulled together a few slides on the data. We likely all sort of know the general take home of the data, which is that the Delta variant, MUSC has just published their most recent numbers. That's not this slide, but this goes through June, but their July numbers, the latest sequencing shows that 90% of the cases that they have diagnosed are the Delta variant now. And so that is no doubt driving some of what we've seen for very high transmission rates, lots of clusters in our community. But basically, and I know I don't have too much time today, but what I want to really emphasize is that the Delta variant is not a major threat to everyone in the US. It's largely a threat to the unvaccinated. We know it is more infectious, it is spreading more quickly, and most people aren't being as careful as they were months ago. So Delta is therefore causing the unvaccinated to get sick, and they're still going to the hospital and they're still dying. So you can go to the next slide, Paul. And this really looks at the numbers. And again, this is from MUSC's Epidemiology Intelligence Project. But basically what it shows, and what we've always known to be the case, is that breakthrough infections of COVID-19 do remain possible. And such reports have become more frequent. But that's because the vaccines are not 100% effective. Therefore, some vaccinated people will still get infected, some will get sick, and in rare cases, some will even be hospitalized. But the success of the vaccines has long been predicated on preventing severe illness, which they do, rather than in preventing any infections. So the vast majority of vaccinated people who do get COVID-19 are recovering and continue to recover with no real issues. And so why are we worried? Why are we talking about masks again and that sort of thing? And the reason we're not celebrating is that none of this is true for the unvaccinated. For them, the pandemic has really not changed. Hospitals are filling up again, especially in states like South Carolina where vaccination is low. And in those places, more people are now going on ventilators and more again are dying. You can go to the next slide for me, Paul. So at this point, I think this slide says 47 cases. We're now up to 53 cases per day per 100,000 population. Our cases in the Charleston area have not been this high since February, and they more than doubled last week. We also see that effective reproduction number is still 1.64 or greater than 1, which means our cases are expected to continue to increase from here into the near future. You can go to the next slide, Paul. So we know that hospitalizations and deaths are also rising in South Carolina, and this is not on this slide, but I just want to sort of put out there weekly hospitalization were 300 2 weeks ago, 450 last week, and now the most recent week that just ended yesterday were 865. So rapidly rising. Likewise, deaths 2 weeks ago were 16. Last week up to 25, also rising. More than 600,000 Americans have died of COVID-19, but vaccines can prevent more loss. And getting vaccinated is an absolute necessity to ending this pandemic. Can go to the next slide. So what we know is that across the country, a vast majority of the severe illness and deaths are among the unvaccinated now. Fewer than 1,200 vaccinated people have died of COVID-19 as of the middle of July, and over 97% of people who are hospitalized for COVID-19 are unvaccinated, according to the CDC. So yes, breakthrough infections and cases should be addressed to avoid possible transmission. And we're still learning about how vaccinated people who get infected may contribute to spread. But they are not the most important, this is not the most important metric for measuring the end of the pandemic. If most breakthrough infections cause colds or other limited illnesses, they really aren't the main concern here unless they start resulting in more serious illness and deaths. And for the most part, we are not seeing that yet. Go to the next slide for me, please, Paul. So what we know is that COVID vaccines work incredibly well, and more than 160 million fully vaccinated Americans are proof of that. Whether the skepticism among the still unvaccinated is rooted in political misgivings or conspiracy theories or a lack of accurate and timely information, there are still millions of Americans unwilling to take the simplest of steps to end this pandemic. Any claims that the vaccines are unsafe or ineffective or that the corners were cut in developing these vaccines are simply not true. And it is incumbent upon all leaders and health experts to be honest about how safe and effective the vaccines are and to urge vaccinations. So this is looking at Charleston, that 57% have at least one vaccine. But, you know, we don't believe that only with the full vaccination series, the 2 for Moderna and Pfizer and the 1 for Johnson & Johnson, and 2 weeks after that, do we assume full vaccination? And we are not yet to the 50% mark for that full vaccination in our communities. And the bottom really looks at age. And yes, we do have less vaccinated that are young people. We are seeing some improvement in those age groups, but that is definitely both our school age children and our young adults that we need to do a better job in reaching and providing information, answering their questions about the vaccine. I also think that ultimately we're going to need to talk about vaccine mandates, and I know some businesses are already doing that, and we're going to need to begin to focus more on incentives. because what we do, and I know I've said this several times before, but I just want to say it one more time, is that COVID-19 is not even close to a crisis for those who are vaccinated, but it is a true danger to those who are unvaccinated in our communities. So I'm happy to answer questions. I know we don't have much time. There have been new guidelines from DHEC and the CDC, and we're certainly working with schools about that and with municipalities. But I want to briefly provide this message because unfortunately, it's difficult to deal with all the other public health issues that we need to address until we can get this pandemic under control in our communities. Thank you.
Thank you, Dr. Richardson. Any questions before we move on? All right, seeing none, we will ask for Dr. Kimberly Butler-Willis for her Health Disparities Environmental Justice Subcommittee report, please.
Good morning, all. So no report today, but we do have our meeting tonight at 5:30. So at next month's meeting, I should have an update.
Okay, great. Very good. Thank you.
Evan,
I'm okay. Go ahead, Paul.
sorry, could I go back to Katie and ask you a question? Katie,
Sure.
with flu season coming up in October, when should we really be looking at trying to talk about vaccinations for flu?
Yeah, that was one of the things I wanted to discuss today, and I will try to put that. Hopefully, I'll be able to not be behind a whole bunch about COVID next month. But DHEC is again going to be going into schools to provide flu vaccines this year across the state, and so we are working on getting sort of all of the things in place to make that happen. We are going to definitely stress flu vaccines this year. We had a very mild season last year, at least in part to all the preventive measures we were taking for COVID, but that does make us very nervous about the flu season this year. And so flu vaccines should be coming out in the fall. We don't believe they'll necessarily be out earlier than, previously, but we will recommend people to think about getting that vaccine as soon as they see their provider or the pharmacies beginning to have those available.
Let's see, Mayor Tecklenburg.
Thank you. Dr. Richardson, I think numbers of cases among young children are on the rise. I know I have a niece who's positive right now, and there's a lot of concern about kids wearing masks in schools. The state has basically disallowed it. I saw yet in this morning's paper that the city of Columbia is considering trying to override that somehow. But you just mentioned giving flu vaccine in schools. I guess, is the COVID vaccine just still not authorized for kids under 12? I mean, can't we do COVID vaccines for kids in schools?
Well, so Charleston County School District is actually a leader in the state and in the nation for being able to provide vaccines in the school systems. And Maggie can certainly tell us more, but Ellen Nitz and her team have been having vaccine clinics in the spring to those 12 and over, as well as for students and parents and staff and the community this summer leading up to the beginning of school. So yes, we certainly hope that it is not yet approved for kids under the age of 12, none of the vaccines, but certainly when it is approved, we will do our best to make it as accessible as possible for those kids to be vaccinated. So yes, certainly in the schools, in providers' offices, MUSC and Roper doing a great job helping Feather to get the vaccine out there. Now we just need the community to come to these events, these clinics, and get vaccinated.
Thank you.
And if I could add in, you talked about vaccines versus the non-vaccinated versus the vaccinated. Just a CDC updated theirs that even if you were vaccinated, if you're exposed to a positive case, their suggestion you mask and then get tested in 3 to 5 days. And then you can take your mask off if you're negative. Where if you're unvaccinated, you're going on 7-day quarantine and you're going to be pulled away and sent home, have to take sick leave or be pulled out. So vaccination really does more than just protect you. It also keeps you from having to take off work all the time because you haven't looked out on the bigger picture sometimes. So that's one of those issues that is really worrying us is that we're starting to see it pop back up more, and what it's going to do to our workforce if it's not vaccinated, it makes a big difference. So
it does. And as we're working through clusters right now, those that are fully vaccinated are much more quickly getting back to doing what it is they want to do, whether that is sports or work or, be in camp, all those sorts of things. Whereas those who are unvaccinated, we still recommend 14 days of quarantine as the most safe way to go. There are the other options, like you said, the 10 days or the 7 days with testing. But yes, to be vaccinated, you are much less likely to get sick and much more likely to be able to continue on doing the things you want to do in your life.
Right. Thank you. Any other questions for Dr. Richardson? Okay. And I appreciate Jason Kronsberg being on here. Jason, I know you're extremely busy. I wanted to ask you if you don't mind, because we are right at 10 o'clock, if we could defer your report to the next time. Would you be okay with that, Jason?
That's fine with me. Just want to make sure respectful of everybody's calendar. So that's fine.
All right. I appreciate it, Jason. I know you've been extremely busy. I appreciate you being on here. It's just, I know that everybody's time is very valuable, and I just want to make sure we respect that in this meeting. So if we could, I'd like to move on to community updates real quickly. And I guess I'll start off with Maggie in Charleston County Schools.
Hi, y'all. Thank you so much for the opportunity to share what we have going on currently. As Dr. Richardson shared earlier, we have been holding a series of vaccine clinics beginning in March of this year with our staff, and then moving into regional sites as the FDA allowed the use of Pfizer's vaccine for younger individuals, now 12 and up. We've had several community clinics at our middle schools and other areas that are open not only to eligible students, but also to their parents, anyone that came in essence. And we also have series of vaccine clinics paired up with our fact and fee nights at schools that started in the past week or so and will continue up until the beginning of school as well. So we are still actively providing those opportunities to those that would like to take the vaccine, ages 12 and up, as well as their family members as we move into the beginning of the school year, paired with our established back to school activities. Some other things in our recent COVID-19 updates, we're focusing on 3-foot distancing more when feasible within our schools, continuing to have our schools cleaned frequently like we did last year, as well as our HVAC filtration levels to continue to be extremely high, and having those filtration systems kept up to date and replaced with the highest quality filters that we can get, as well as our contact tracing efforts. Those will also continue, and those have continued throughout the summer in our summer programs as well. Because of the state proviso 1.108, face coverings are not currently required. So we will be continuing to evaluate things as we lead up to the beginning of the school year. However, masks can be strongly encouraged. But, officially per that proviso, per the state mandate, face coverings are not required at this time. Other things that are currently under review are frequency and type of COVID testing for staff and students for this upcoming year, as well as some of our fine arts program requirements and our event seating. So we're still evaluating what those pieces would look like for this upcoming school year.
Okay, thank you, Maggie. Any questions for Charleston County Schools, Maggie Dangerfield? Okay, we will move on. Kimbo Yee, do you have anything from the Citadel?
I'll just be very brief. So our students are starting to return to campus. We have about 500 leadership students returning tomorrow, and we'll have the next couple thousand returning over the next 2.5 weeks. A public health question that I've been asked recently is, will we institute any kind of mask mandate? And Maggie already brought this to attention, but based on the proviso from this past summer, we cannot. So if anyone saw the story, the University of South Carolina had implemented a fall mask mandate last week for faculty, staff, and students, and then yesterday repealed that mandate based on the Attorney General of South Carolina recommending that the proviso prevents a mask mandate. So it seems like the Citadel, as well as most state-funded colleges in the state, will not have the ability to institute any kind of mask mandate this fall. But just like Charleston County Schools, we'll be maintaining preventative measures, hygiene measurements to the highest efforts. We'll likely be offering vaccine clinics throughout the year to faculty, staff, and students. We've had a couple over the summer for faculty and staff that were around the area. And yeah, that's our biggest updates. And we'll still likely have quarantine housing availability for students that might eventually get sick this fall. So
thank you for that. Appreciate that. Meredith Belinsky, anything?
Actually, I've had quite a few things Representative Francis is doing for the community and other things involved, but I kind of wanted to throw the applause and the appreciation to Dr. Richards for Katie putting that out there, that we're seeing that flow right now in the Representative Francis system of our COVID patients, of our hospitals filling up, of getting additional help coming in to assist our staff and assist our system as a whole. So the big thing is a vaccine, and like you said before, we've offered it to when it first came out, the mandates for different ages and whatnot, and we went down the line. We went to the parking garage at the North Charleston Coliseum, and we gave vaccines there. We're pushing it as far as we can. It's just a matter of our people coming in and getting it. We're offering it at all of the urgent care centers, Representative Francis Urgent Care. You can call and make an appointment. You can show up. You can talk to somebody there. It's available. So all the other opioid related things, the things we're doing with the community, the things that Representative Francis is trying to help, is everything's running as planned. But I think the biggest emphasis we just want to put is just for our community to grab and understand this vaccine, and just like Dr. Richardson said, it's worth it, it's safe, and we need it.
Thank you, appreciate it. Let's see, Stacy Mathis, did you have anything you wanted to add?
Sure, just real briefly, following up on the discussion about suicide earlier, I just wanted to let you know that Department of Mental Health has had a zero suicide initiative for years that looked at training our employees and our admin staff and our therapists with the goal of preventing all suicide. Through a grant with Blue Cross Blue Shield of South Carolina Foundation, we are going to start rolling out trainings to community members, everyone from faith-based organizations to just sort of community leaders, hospitals at various levels, hoping to train and partner with community members on recognizing risks associated with suicide, what to do when you hear something that's concerning, and then looking at sort of training the trainers with community leaders. It's called the Communities of Care Network. And so hopefully I can send this information out. It'll have some contact information if anyone is interested. Unfortunately, Charleston County has one of, we're in the top 10 for suicide risk in South Carolina. So Charleston County has been offered the opportunity to train community members. So if anyone is interested, I'd love to connect you with the folks that are rolling out this project. And I'll try and send, do I send it to you, Paul, some information? Great. And if anybody's interested, you can reach out to me, or there's also contact information on these flyers. Thank you.
Thank you so much. Appreciate it. Nick Osborne, you have anything you would like to share?
Yeah, thanks very much, Kevin. Just very quickly, I guess in terms of, as expected, I mean, the need and demand for food assistance continues. We're still seeing the continued need across various populations for support. We are putting in place a number of different approaches and continue to pivot in terms of being able to meet that need, in terms of looking at opportunities for pop-up distributions, for example. But I think, given the situation at the moment and the uncertainty with regards to the removal of certain benefits, what that's going to mean moving forward in terms of the impact on those that are most vulnerable is something we're continuing to track. We are seeing a sort of a slight uptake in terms of those walking into the facility looking for emergency assistance in terms of food. I think also in a COVID context as well, the uncertainty of what that means in terms of how it's going to impact people as well, especially in terms of those that are having to be faced with a choice of whether to return to work or not, or look for employment opportunities. What does that mean in terms of vulnerability to COVID, and therefore choices as to whether to return to work or not? Just in terms of our own precautions here in the food bank, obviously we want to continue to be able to provide whatever service that we can. We have instituted the wearing of masks again in the facility here. That's both for staff, also for visitors and for our volunteers as well. But we've done that obviously to provide the greatest safety to those that are in the facility, but also to enable us to be able to continue to work in the days ahead.
Thank you very much. Joey Curran.
Thanks so much. Yeah, so Trident United Way has just really been working hard to facilitate conversations around vaccine hesitancy amongst our community members. I want to acknowledge and thank Kim Butler-Willis for moderating our most recent conversation where we've been working with community members to try to, educate and alleviate any potential hesitancy that folks may have. And so just wanted to let this group know, and Mayor Tecklenburg, if there are any other groups that you would like for us to help facilitate that conversation with, we are prepared and practiced in our ability to do that.
All right, thank you, Joe. Is there anybody that I've missed that wanted to speak on our community updates? I think I've covered most of us.
Hi, this is Susan.
Oh, hey, Susan. Okay, thank you for joining.
Hi, sorry, I've been having to stay muted, but I did want to just share a quick update. I was tied up until 10, but I just wanted to share an update on the Kappa Heat Watch. We were successful in collecting data across the city on Saturday, which fortunately or unfortunately, depending on how you look at it, we did have a heat advisory. So I think our efforts to pinpoint the best day in working with our local NOAA folks paid off. There were some storms later that afternoon, but I think we really captured some great data that will not only go into the pool of 22 other cities across the country that participated, but will also really help the teams in our local areas, and then the Heat Health Coalition between North and South Carolina, the researchers from our higher ed institutions that are working on this issue. And then we also wrapped up the other heat study that we were doing with our grounds workers and security. So we plan to convene a group sometime this fall in Charleston to review the data and talk about mitigation efforts and how we can really use this information to positively impact our community and put mitigation efforts into place. And Jason, I don't know if you're still on, but I did have a conversation with the president of the Charleston Tours Association, and they are very interested in supporting our efforts, and would like to fund some hydrating stations, maybe in some parks in the city that they tend to visit with their tour groups. So we can take that offline, but I just wanted to share that because I think that it is something that this group has discussed. And to me, it's very similar to what we did with the sunscreen dispensers. And I think it's just great that if our committee can endorse that as well.
Great. Thank you so much for all your work on that. I appreciate it. I know everybody does. I see Lori Yarborough popped on. Mr. Mayor, did you have
This
something
is
for-
Aretha.
Oh, Aretha, go ahead. I'm sorry.
I just would like to say that we ramped back up our testing. So we're offering testing at all of our locations 5 days a week. And we have definitely seen an increase in the amount of people testing. Last week, we saw about a 17% positivity rate. So we increased our hours this week. And then we're also doing vaccines every day at all of our locations. That's all that I
Great.
have.
Thank you, Aretha. Can you announce those locations so everybody will know? Aretha? There you go.
Paul, is 24 of them.
Oh, I'm sorry.
You can look at our website on one of the main locations on Meeting Street at the 51 Nassau Clinic.
Okay, great. Thank you so much. Mayor Tecklenburg, did you have something?
So if I may just kind of close a comment with about the vaccines. And I'm going to say that one of the saddest things that happened in our country over the last year and a half is that a major public health emergency, if you will, became a political issue. And unfortunately, that continues to play out even in this conversation ongoing about wearing masks still. And, you know, be it politics or just folks in Columbia knowing better what's for our lives than we do. You know, you can have your opinion. We can have our opinions on that. So here's the thing. I think rather than, you know, worrying about masks, everybody's calling me in the thing in the paper this morning, mayor needs to put another mask on. Let's not worry so much about masks. Let's get everybody vaccinated. And I know everybody here is on this team, and you all have, you're giving out the vaccines and all like that. The awareness right now is elevated because of what's going on with the cases and all like that and the news. So can we all commit in the month of August to double down our efforts? Everybody have another clinic, put the word out again, all your social media, every way that we can try to communicate with people. Come on, y'all, come in and get vaccinated. That's the bottom line. That's how we're going to control this pandemic, is to get vaccinated. It's not going to be by wearing a mask. I'm going to recommend it, but we just need to double down. This is the perfect month to do it, in August before school starts. And I know you're all working as hard as you can already, but just let's give it the extra effort in the next few weeks and the next month to try to get more people vaccinated. So thanks.
Thank you, Mayor Tecklenburg. Lori Yarborough.
Thank you, Councilmember Shealy. I have listened the whole time, and I, like Susan, tried to keep my mic off because I knew if I started talking, I wouldn't stop. But I was very disheartened the first 40 minutes of this meeting to hear all of the news in terms of violence and gun violence and murders and suicide. And I just linked that. I know it's all a big public safety issue, but it's also just an integral part of where we live and work and play. And I'm going to continue to support Susan and the health and all policies as we move forward in the city and push that, because the mayor's right. At 16, 17, 18, these young folks are hardened. We've got to get them in our parks at 5 and 6 and 7. And that's especially true in those area codes of 29403 and 29405, and in parts of West Ashley and James Island, where we have a lack of fathers and role models, and kids are raising kids, and I could go on, but this gets at the heart of Parks and Recreation. And so I'm going to continue to bang that drum until I drop, and say that Parks and Recreation have to be a part of that. We have to figure out how to get great mentors. The mayor's doing an excellent job of stirring that up with Mindy and getting that going. But we've got to have mentors working with our children, especially our children in the areas that need us the most. So I'm going to shut up. We've got about 5,000 kids signed up for fall sports. It looks like parents are ready to go again. We'll be as safe as we can possibly be. We've had very few outbreaks this summer. Last couple of weeks have been a little more dicey, but anyway, it's been a good summer in recreation, and I'm appreciative of the mayor's continued support for Parks and Recreation through the Parks and Rec Master Plan, through trying to get funding, and through keeping that emphasis there. Thank you, sir.
Thank you, Lori. Thank you very much for all that you do. Appreciate it. Is there anybody else I missed under community updates? Anybody have anything they want to share? If not, I want to thank you for your time. A lot of great information. I apologize. We went over by about 20 minutes, but I think it was worth our time. We had a lot of incredible information. I apologize to Jason and Lori for not being able to get them in, but we will get you in on the next meeting. And just want to tell you how much I appreciate your expertise and your time that you commit to the city of Charleston and to this committee. So if there's nothing else, I will call this meeting adjourned. Thank you so much.
Thank you, Mr.